Thank you. All right. So when Sunir did his drugs in the news, this is so hot off the press that it didn't even make it. So we have a new medication called Jetrea, and I'm not sure how to pronounce it because I've heard, this is a fabricated word, so anybody, you can basically say it any way you want, I think. Jetrea? But anyway, it's been in the news lately, and I wanted to go over how that may change our management of holes and traction. So our research department at Wills was a center for the studies, so we do get research grant support, but I don't have any other financial interest. So when we look at vitreomacular traction, we look at it as a spectrum, and I'm going to argue that actually macular holes belong within this spectrum. So here we see something from the most focal area of adhesion of this is again the vitreous for those of you who are not familiar with these pictures, but to a broad-based adhesion. Right now, a month ago, the standard of care for vitreomacular traction was see if the patient's symptomatic, and if they have distortion or decreased vision, you operate. That's really it. Or you observe. So we observed a lot of these patients, but we knew that some of them would get worse. But the risks of the surgery were just not outweighed by the benefits. So, but the technique is fairly straightforward. You go in, you remove the vitreous, and you remove the traction. Sometimes you can stain to make sure you've gotten all of the traction, but you didn't have to. You didn't have to position unless there was a hole. But most patients, the majority, did get an improvement. So that was a very nice treatment, but aggressive for patients with minimal symptoms. So here's an example of a 20/70 eye with, again, a little bit of an epiretinal membrane. But here you can see, by virtue of our OCT technology, that the vitreous was exerting traction. After surgery, the patient did much better. And in my experience, I don't know about anyone can comment, many of my patients, even after surgery, their foveal contour never looks quite right. You always have that. And a lot of patients still complain, but I think it all has to do with their expectations. They're just not completely cured, even though the traction's gone. So if you look at some of those pictures, it's not that far off to see the difference between now a macular hole. And you have to admire Don Gass, who, before the advent of OCT, actually drew pictures of what he thought this was happening and looked like, and he was right on the money. He had described the stage 1, 2, and 3 macular holes without the benefit of OCT. And so essentially, you have a vitreomacular traction where the forces are such that instead of just pulling the whole retina up, it actually, something starts to give. And this we call a stage 1 hole if there's no break, stage 2 when it's still attached, and 3 when there's not a full PVD, but the hole is full thickness. I'm going to now show you I just collected some OCTs, but they're basically showing that this is not one or the other. This is a spectrum. So here we have, depending on who's looking at it, they may say that's VMT with a focal adhesion, or this could be a stage 1 macular hole, depending on who's looking at it. That goes on to a little bit more traction. You now see distortion of and by the way, this patient may have 20/20 vision and be completely asymptomatic coming in for an OCT for their fellow eye, and this is what you see here. Now we have a little bit of distortion. Now we have even more with some cystic degeneration occurring because the retina is being pulled. And now you actually have this telltale area here where you know that something's going to have to give at this point. You can almost see the cleavage plane where the hole is going to form on this OCT. So, again, many of these patients used to come in with 20/30, 20/20 vision and minimal symptoms, and it was always the dilemma, what do you do? There's the stage 2 hole forming. It's sort of like I describe it like when you open a can with a can opener, you always have that little flap. Depending on which cut you take, this may look like a full thickness hole or no hole at all. Here's a very good example of a stage 2 hole where this flap, you can actually see this side's free, but here's where the flap is attached. And This is a stage 3 hole, but again, remember that little piece that we saw at the beginning? That is now what we call a pseudo-operculum. And we know from the macular hole patients postoperatively that this probably doesn't really have anything important in it, because a lot of these patients will get most of their vision back. If this was really retinal tissue that had anything of importance, they wouldn't see as well. This is a large macular hole with a lot of edema, but you can imagine if you laid down these two sides that there's enough tissue to meet up. And that's important, because as these holes become more chronic, you actually lose tissue. And even if you flatten them, they just can't meet, and they're always left with a scotoma. Now, what about cases like this? Well, this is a patient, we call these the pseudo-operculum. This patient probably had a stage 1 hole, and the old teaching was that 50% of those patients would get better by themselves. So this patient spontaneously regressed. You can see now the hyaloid is completely separated from the back of the eye. So with macular hole management, again, surgery was the only option we had. And most of you are familiar with the techniques. Most people will use ICG to stain the ILM, which gives you a higher success rate. And you use gas. The big question nowadays is whether you need to do face down, and if so, how many days. But the success rate is fantastic. And this was really a big step, because even when I trained as a fellow, we weren't really doing macular hole surgery at that point. And so here's the surgery. Stage 2 hole, closed hole, good recovery of vision. So one of the things that you need to understand, this is the two-dimensional, the OCT, but when you're doing surgery, it really has given us a lot of clues over the years. This is an eye that's had triamcinolone used as an intraoperative adjunct to visualize the vitreous. And what I've noticed, and what most people have commented on, is there are two really firm adhesions. One is around the optic nerve, and one is in this area of the macula when the vitreous inserts in. Almost every eye that we do with macular hole does not have a PVD. Even if they have a ring, they don't have a PVD over the macula. So here's some video, and I just wanted you to see how that vitreous reacts, and you can see it. It is very adherent to the back of the eye in these eyes. This is the pathology, the underlying pathology in all of these conditions. So using the triamcinolone, you can stain it. Now you can actually see when you get a PVD, let's take a look here, there's a Weiss ring. A Weiss ring is just where the vitreous inserted around the optic nerve. And you can see it's not an easy task, but both the macular insertion and the optic nerve are firmly adherent in these eyes, which is the underlying pathology in these conditions. Once you remove this posterior attachment, the remainder of the vitreous just pops up like a PVD. In many of these cases, while we're doing this and we're removing the vitreous, we will actually see horseshoe tears develop in the periphery. Again, look at that Weiss ring. Isn't that amazing how you can mimic what happens in the natural history? So in these cases, that has really taught us a lot about what's happening with the mechanism. Again, a firm adhesion here and a firm adhesion here. So that now leads into the next area, which is, can we do that, what we're doing mechanically in the OR, can we do that pharmacologically? I mean, we inject everything now into the eye. Why not inject something that can enzymatically cleave that vitreous interface to release the vitreous from the retina? And that's really what prompted the search for one of these new agents. The benefits of it, of course, is you don't have to go to the OR. And so it's convenient. We know that every patient that gets a vitrectomy within 6 months to a year, give or take, will get a cataract progression. And wouldn't it be nice if you didn't have to physically pull like that, like I was doing in the OR, and to remove it? So ochraplasmin is also known as Jetrea, and this was looked at as a potential agent for vitreomacular adhesion. It is actually, just like Lucentis is the business end of Avastin, this is actually the active part of the plasmin. It's manufactured with recombinant technology, and it targets these vitreous components and digests them, basically. It separates the vitreous from the internal limiting membrane. So not only does it cause a PVD, it also causes liquefaction of the vitreous. So in these mouse eyes, we can see the vitreous body tightly adherent here to the internal limiting membrane. And then after injection with ochraplasmin, you see that there is a PVD. The vitreous is now here, but you can also see the vitreous is a lot less cellular, if you will, with liquefaction. So you get two components. Now, other agents have been looked at, and basically, it's a busy slide, but when you look at the risk and the benefits, the best, without any of the disadvantage and all of the advantages, we have ochraplasmin. That's known as Jetrea, and I just want to note one thing here. This needs to be stored frozen at or below -4. Now, your normal refrigerator or freezer is not going to be able to do this. So this does create some issues, but this is a frozen enzyme that's basically defrosted at the time of use. To prepare it, you take the cap off, you wipe it with alcohol, you add sodium chloride to reconstitute it. And by the way, I didn't go through, it's frozen, so there are many techniques how to defrost it, some of which I can't safely show as a video. But basically, you defrost it any way you can. Leave it on the table, or some of our technicians have really created very interesting movements that they do to get it defrosted. But you add the sodium chloride, you shake it, you draw it up, and it's injected just like Avastin, Lucentis, Eylea. And you inject it into the eye. Yes, Ralph?
How long does it last after it's...
Not long. It's immediate. I literally walk it over and bring it. Have the patient's already prepped and ready. Maybe that's, I don't know the exact number. I can look that up, but we use it immediately because it's basically an active enzyme. Now, we knew from the initial studies that actually just injecting anything into the eye, the vehicle, will resolve VMA. And we've talked about that before at one of these conferences. Why is that? Well, you're injecting liquid into the vitreous, and perhaps you'll pop off the adhesion. But the Jetrea itself is doing a lot. So why do we care? Because if you remove the adhesion, it improves the vision. Okay, so if the patients where you did not resolve the adhesion, they did not improve, and those where it was resolved improved significantly. So when we look at the studies, these were dual studies, both here and in Europe. And basically, you had to have VMA confirmed by OCT, and you were randomized to placebo or the drug. And the inclusion criteria were quite nice, that you really didn't have to have very poor vision. So if it was worse than 20/25. Obviously, you wouldn't want patients who had prior vitrectomy and large holes. But in general, it was a pretty easy recruitment, and you could either have VMT, full-thickness holes, or epiretinal membrane. And I'm just going to cut right to it. The epiretinal membrane patients did not do well. And as you would expect, if the epiretinal membrane is growing along the surface of the retina and it was thick, this is not the right drug. This is only for those cases where you're lifting up on the retina from the vitreous. So you can see that the patients who received the drug had a significant resolution at day 28 of the vitreomacular adhesion. And again, if they had VMT, this is without the hole, the success was excellent. Now, as Mark asked before, is smaller better? I'm going to answer that right now. Yes. Because if you look at, as you define the size of the adhesion, this is less than 1,500 microns, the optic nerve diameter, or greater. The patients who had the smaller, less than 1,500 microns, did much better than, and that makes sense because you have this very broad adhesion and it's much harder to break that. But all patients, again, almost all, had the mean visual gain was almost 8 letters, and very few did poorly. Most patients did very much better. When you look at the macular hole subgroup, and these were patients with some type of vitreomacular traction, okay? It makes sense. If you have a wide open hole with nothing pulling, why would doing anything that dissolved the vitreous help at that point? So what about eyes like these? Again, these were not, even though you have a small hole here, not a good candidate. Why? Well, it already happened, what we're trying to induce. So if you look at the patients with full thickness macular holes, much better with the Jetrea. So these are great for those small holes with good vision that you're not quite sure you want to take them to the OR. This works very well in that subset. So does size matter? Yes, it does again with holes, because the smaller holes did much better at a month and 6 months. And I want to point out one more thing. If you don't see a closure by a month, it's done. It's not going to be a late onset improvement. So you can tell the patients at 1 month, if it didn't close, it's time for surgery, and because it's not going to get any better. Everybody, except for one patient here, got better. But of course, those are the ones who closed. If they didn't close, they did not get better. So here is an example of a case where exactly the stage 2 hole, it's released. You can now see that pseudo-operculum, and this patient had a marked improvement in vision. So here's another example, pre-treatment, improvement, but the important thing is the hyaloid is now up at day 28, and by 6 months they have restored their foveal reflex. So now, this was my first case. I did this patient about a week ago, and here she was. This was the ideal candidate, a stage 2 hole with about 20/70 vision. You can actually see the hole forming already. And this is all I have to show you so far. This is 5 days out, but we got the release. So this patient, even though she was seeing much worse, this patient's prognosis is good, and you have to imagine that now that this is released, if these 2 layers can touch, you know, would I love to have a gas bubble in there to push back? Sure. That'll be for the next study. But right now we're going to see if it happens by itself. If patients, this is again proportion of patients with closure, if you have the drug, and this is an important question everyone asks, and it doesn't work, does that mean that your vitrectomy is less likely to work? No. So there's no downside to doing it. If it works, it works. If it doesn't, you can still have the same surgery that you would have had in the first place. So safety, this is important because I wasn't expecting, both of my patients that I did my first treatment on came in during that next week and said, I am much worse. And now, you know, you basically, is borne out what the studies show. They're much worse, and as expected, you're dissolving the vitreous. Tons of floaters. Some of them have pain, flashing lights from the traction, but that is, and again, a little bit consistent with getting the vehicle as well, but that's expected. And by 1 week, you're not expecting a closure. In fact, here's the baseline. 1 day after injection, a dramatic drop. But a month later is where you have to look at it. So that's something you can tell the patients, and if you get a call about a patient who's had that, you understand it is normal to get worse before it gets better. That's the take-home message for me. Patients had tears more likely in the placebo group, but because the reason is more of them went to surgery, and as I showed you, when you lift that hyaloid, you're much more likely to get a tear. So actually, it is not a higher incidence of tears, which is nice. So in conclusion, these are the take-home points that I've gotten from this single injection. And by the way, repeat injection is really not indicated. If it doesn't work, that's pretty much it. You have a very nice rate of resolution of holes and vitreomacular adhesion, and that results in improvement of vision in most patients. If they did have an adverse event, it's usually transient and early, and it did not negatively affect your ability to perform a vitrectomy later. Some other considerations: if you have focal adhesion and smaller holes, those patients do better. And you should inform them that their vision will worsen before it improves. It's not something for every practice because it requires a special freezer that is able to get cold enough to store this at the appropriate temperature. And right now, we're only ordering it as needed. We're not storing this because I do think there's a lot of issues with doing that and making sure that it's always kept at the appropriate temperature. So we're ordering it and immediately using it. And of course, as we've heard, we don't know yet how far we can go with this. But obviously, how about that traction detachment case in a diabetic? That would be really nice either to do that preoperatively or to do it in lieu of surgery. And the billion-dollar market is right here. If you have a patient with a big floater that's kind of stuck and they're really bothered, could you inject this and dissolve it enough to have it move out of the way? Who knows? But obviously, at $4,000+ a treatment, which that's not something you're going to do all the time. So, yes.
Are you giving floaters to people that don't have a PVD?
Yes. We are giving floaters to them, but it usually is temporary.
Just one other thing that might be notable for the anterior segment surgeons. There was a small incidence of lens dislocation in the clinical trials, but in the animal studies, going back to your comment about injecting a second time, and when they looked in mice, they had a small incidence of lens subluxation with one injection, but when they did a second injection, I think the rate was 100% of mice had their lens subluxated. So if you're taking care of a patient who has a cataract after Jetrea, you might want to consider them similar to like a pseudoexfoliation.
And warn the surgeon so that when they get in there and the whole thing starts moving around. So maybe we don't know this yet, but maybe we're losing some zonular stability. And what do you do about patients with pseudoexfoliation? Would you not do it in those patients? I have no idea. Only time is going to tell. You don't have enough patients in these studies to be able to make recommendations yet. Yes, Raj.
So, like, the biggest knock on hyaluronidase was that it chewed up the core vitreous, but it didn't create a PVD. What do you think about doing a cocktail, that and ocoplasma, really super digest, right before?
Maybe we should do Avastin too, and steroids, and just.
And it's just like slurping through.
What do I think? Well, I mean.
Like, well, hyaluronidase.
I don't want to have. I don't want to end up digesting someone's eye inadvertently. So. I don't know. You'd have to do a whole new study, but that's a good question to have a half and half kind of thing. Yeah.
How do you follow them after the injection? How often?
Well, I mean, if you look at the studies, it was one day. So I actually did it on a Friday, and I got a call I called one patient on Saturday. She was doing great. The other patient actually had to come in because he was really bothered. But again, just floaters. But I think now, knowing that, I'd probably just see them the next day to reassure them because they are going to get so much worse, and you can't explain that to someone before it happens. He said, I think it's a little bit better in the middle, but I can't see anything. It's all grayed out. And that really, he was about 2,100, and it was all the floaters. So I think I'm going to follow them at 1 day and 1 week, just like you would a post-op for the time being.
And that's probably right, because if somebody calls you on the phone the next day, they're going to have more floaters, their eyes going to be red because of the shot, their vision's going to be down. So it's hard to screen out if it's endop or is it just symptoms after the Jetrea. So
bring them in if in doubt, because it's such a new drug. We just don't know.
What's the half-life of that Jetrea in the eye?
I don't have the answer to that. I don't know. It's short though. The half-life is a very short period.
Yeah, it's pretty much gone within 2 weeks.
Right.